Hey, good morning everybody. My name's Ben Greenfield. I'm an associate professor of perfusion at the University of Nebraska Medical Center and also the director of recruitment and retention for perfusion.com. This morning we're going to be talking about shunts and shunting of the extracorporeal circuit. The first thing we need to know about shunting is what we deem a shunt to be. And we deem a shunt to be anything that takes blood away from the normal circulation of ECC. That means anything that we take post-oxygenator and shunt that, which is why we call it a shunt that back to our reservoir prior to entering normal circulation through the aortic cannula or to the head and to the body to come back through normal circulation. So anything that we consider that's taking or robbing from our normal effective flow or our effective circulation, we're going to use to describe the word shunt. We're going to talk about four different shunts today of our extracorporeal circuit. We're going to talk about how different they are and then some of the similarities. But when we talk about that, we're going to talk about anything that we put into our circuit that robs our effective flow to our patient and goes back into our reservoir. So the four shunts that we're going to talk about today are the Recirc line, your sample Purge line, the cardioplegia line, and a hemoconcentrator or ultrafiltrator. Those four fundamental shunts are the ones that we're going to be talking about and dealing with, how they're different. Okay, so the first one that we're going to talk about, it's a normal shunt on almost every single circuit. That's our recirculation line. Now, the purpose of the recirculation line comes into play primarily during priming. There are some different times that we use the recirculation line. For instance, if we have a patient that is simply too large or too metabolic for us to adequately ventilate with our oxygenator, we may recirculate blood back through our oxygenator a second time if we have an oxygenator failing or something like that, where we need to recirculate the blood back through. We also use the recirculation line to rewarm in certain cases, like a deep hypothermic circulatory arrest case where we've been arrested and we want to start to recirculate and warm our perfusate so we don't get any static or stasis of blood. That's another time, but primarily our recirculation line or our Recirc line is going to be used for priming. That's the only time we're going to use that, chasing blood back into a bag or things like that, but primarily during the priming of our bypass circuit, that's going to be open. Then once our circuit is primed, we're going to shut that arterial Recirc line, close that off, and keep that closed for the remainder of the procedure unless it's not needed. We do that because that's a shunt that sometimes is a 1/4 inch piece of tubing that a lot of flow is being shunted around our patient essentially. So we want to keep that shut. Remember now, we've talked about Passuet's equation. I even have a video on YouTube here discussing, I think, Passuet's equation. Passuet's equation has to do with the radius of a tubing, whether that's the cannula, whether that's our tubing, or whether that's the patient's vasculature and how that changes with vasoconstrictive or vasodilute drugs. We deal with Passuet's equation, and the radius is a logarithmic. It's radius to the 4th power in Passuet's equation. So essentially, as we open a shunt like the Recirc line, the radius, a large shunt, has a logarithmic effect of flow through that shunt. And the radius of the tubing that is used becomes the determiner of how much flow goes through that shunt. So it's the radius of the shunt, because we know fluid follows the path of least resistance, correct? So it's the fluid shunt, the radius of the dynamics of that shunt that governs how much flow goes through that shunt. Okay, the second shunt that we're going to be talking about is our hemoconcentrator. Now, this isn't in every single CPB circuit. It's something that a lot of perfusionists add, although as MUF and ZBUF has gotten bigger, we've had a push to conserve blood product usage, hemoconcentrators are used in roughly half of the procedures done today in almost all pediatric cases. So a hemoconcentrator is a shunt. It robs blood, arterial blood, from the patient's circulation and goes back into our reservoir, even though it goes through a different device, and that allows us to pull fluid off the patient, much like dialysis would do for a patient with renal failure or things like that. So the hemoconcentrator shunt often is 1/4-inch tubing, so it's a very large shunt. You can get 1 liter or 2 liters of flow through that shunt. It's really important that we regulate that shunt to understand the difference between our measured or our effective flow, which we'll get into in a minute. The third fundamental shunt that we're going to talk about is our sample purge line. Now, again, Passway's equation governs flow through that shunt. It's a pretty small piece of tubing, right? But we'll find, we've measured, and in this lab, we're actually going to talk about, you can get 1/2 liter, almost up to 1 liter under ideal conditions, through our sample purge line at different times, especially if we have a lot of resistance governing flow towards our patient, or the primary direction that we want flow to go. We can get 1/2 liter of flow under normal circumstances through that shunt, so we need to compensate for that shunt as well. It's a shunt that stays open throughout bypass, so we definitely, as a perfusionist, need to think about that shunt. The fourth shunt that we're going to talk about is our cardioplegia. Now, the cardioplegia is a fundamentally different shunt than the previous 3 that we've talked about. The reason is kind of twofold. The first 3 shunts take blood that goes right off of our post-oxygenator, and they go directly back into our reservoir. So they're not going through normal circulation, they're just bypassing that circulation, creating a recirc around back into our reservoir. The cardioplegia is different. The cardioplegia actually does go to our patient. It just goes into the heart, empties back into the coronary sinus or the aortic root vent or whatever, and comes back to our circulation that way. But it's fundamentally a different type of a shunt because it does go to the patient. It doesn't just bypass the patient itself and go back into our bucket. The second reason this is a fundamentally different shunt is it's the only shunt that has a pump of its own, and we can tell exactly how much flow is being taken away from our circuit by this shunt. So oftentimes we'll turn the cardioplegia on and we'll say, okay, we're taking 250, 300, 350, up to 500 cc's possibly away from our flow to our patient, and putting that then through the patient and eventually through a vent or through our venous cannula back into our reservoir or our bucket. So those are the 4 main shunts. 3 of them are similar. 1 of them is kind of fundamentally different for a couple reasons, but those are the 4 shunts that we're going to talk about today in this lab. Okay, so we've covered the 4 different shunts and how they're different. The next thing we need to talk about is measured versus effective flow. Now, your measured flow is exactly how it sounds. Your measured flow is where your flow is measured and what the readout is that you're reading. We're going to get into in a few minutes the difference between the centrifugal pump and the roller pump. But for right now, I want you to think of the roller pump, the raceway. The measured flow is a readout right on the console itself. It's factored just by the amount of fluid in the tubing times the number of revolutions per minute. And it's an equation that we've derived here in lab early on in the semester. So we know kind of what we're talking about as far as the measured flow. The roller pump gives us a measured flow. It doesn't generally have a flow probe that you can choose to place wherever it's at on the circuit. Whereas the centrifugal pump uses a flow probe that you can choose to place as a practitioner, as a perfusionist, where throughout your circuit you would like to measure your flow from. Effective flow is the flow that comes through the aortic cannula in the aorta that actually goes to normal circulation to the head and to the body before it returns through the venous system back to our heart and lung machine. So that's the difference between measured flow and effective flow. And it's a little bit of a difference between the centrifugal pump and the roller pump. The other thing we need to think about in terms of the roller pump versus the centrifugal pump is the way the pump functions in and of itself. Now, the roller pump, we know, is afterload independent, meaning when we increase the resistance, whether it's in our vasculature or a clamp or a kink in the tubing or whatever it is, that pump is going to continuously pump at the readout at what it's designed. It's why concrete can be pumped up stories of a building using a roller pump, whereas a centrifugal pump is afterload dependent, meaning that as the resistance goes up, we have to increase our RPMs to generate the same flow, because as the resistance goes up, flow will come down at the same RPMs. Do you notice what I'm talking about with the centrifugal pump now? What the relationship you need to know and have marked down on your chart as we start to open up shunts with the centrifugal pump and fluid starts to take paths of least resistance, and all at once maybe the same flow will be going but the pressure will drop and we need to compensate with our RPMs. We need to know the relationships between our RPMs, our flow, our pressures, meaning the pressure of the patient and the line pressures and things like that, establish a relationship so that we can do simple proportions to tell what we have to do to compensate for a certain type of flow. So the pumps, the fundamental difference between the pumps, the roller pump and the centrifugal pump, have to do with whether that pump will continue to pump or not based on the resistance that it faces. So now we're going to get into a little bit more about what this effective flow versus measured flow tells us. The measured flow tells us exactly what the pump is pumping. So it comes directly out of the pump. For a centrifugal pump, that would be placing the flow probe either just prior or proximal to the pump or just distal to the pump. That will tell us exactly the flow that comes into the pump or out of the pump. That's our measured flow. On a roller pump, it would be at the roller head, what that pump is delivering while it's turning. So what does that mean for us as a practitioner? What are we concerned about? Are we concerned about the measured flow or the effective flow? The long answer would be both. But as far as taking care of our patient, what matters more to us is the effective flow. We need to calculate based on our patient's body surface area and make our different adjustments based on body dynamics and body mechanics. We want to then think of how much of that flow is actually reaching the head, is reaching the body, is reaching the different organ systems. That's the effective flow. And here is where shunts come in. Now, if we have a roller pump and we are flowing at a certain amount, every shunt we open is taking an amount of that flow without showing us any change on the readout. So what that is telling me as a perfusionist is what my measured flow is nowhere close to what is actually going to the patient. All this fluid is taking the path of least resistance. It's going through my sample purge line. It may be going through an open recirc line. If my hemoconcentrator is open, it's definitely going through that. So the flow is taking the path of least resistance and less flow is going to my patient. With a centrifugal pump, we can decide where we want to measure our effective flow. Now, there are different trains of thought. We could measure it as it comes out of the reservoir. We could measure it just distal to our pump. Those would give us kind of a measured flow that's just what the pump is pumping. We could measure it after the cardioplegia has come off or right after the hemoconcentrator has come off. What I would suggest, and what you'll see most often in practice, is a perfusionist will measure their effective flow just proximal to their patient, or the most distal thing in their circuit, because that gives us a real good idea exactly what is going to our patient. We take all the confusion out of it, because if the recirc line pops open or we open our hemoconcentrator, we don't care as much about how much flow is going through that as long as we know how much flow is going to our patient, to the head, to the vasculature, to the body. So if we're using a centrifugal pump and if we're measuring flow distally in our circuit, so just proximal to our patient on the line that goes to our patient, the arterial line, we take the guesswork out of this. But if we have a roller pump, or if we're measuring flow someplace else using our centrifugal pump, we as a perfusionist have to compensate. What does that mean? That means that any blood that is taking any of the flow dynamics that change from our effective flow, we have to compensate our measured flow that same amount. How do we know that? Well, with one shunt, it's fundamentally different, right? The cardioplegia, that means we turn our cardioplegia on, it takes 500 cc's away. We need to compensate 500 cc's with our roller pump. But the other pumps, the recirculation line, which we shouldn't be running under a normal situation, shouldn't be open. Our sample purge line, maybe that's a half liter. Maybe we open our hemoconcentrator and we get a flow through that. We as a perfusionist then need to compensate how much that shunt is stealing from our effective flow to our patient. This is one area of perfusion, and we'll see throughout this semester, if you don't have a great and a super understanding of effective versus measured flow, you can harm your patient, you can cause damage, you can even cause death, because you can be tricked into thinking that you're delivering 5 liters a minute, where in fact, you're delivering 1.5 liters because all of these shunts are open and robbing from our effective flow. And that's really, really dangerous. What this lab is designed to do is to investigate these different shunts. We're going to set up these different shunts and we're going to see how much flow is actually taken from these different shunts from our effective flow using a centrifugal pump system and using a roller pump system. So we'll set up both and we'll see how the pumps differ in the roller pump versus the centrifugal pump, how much flow goes through the same shunt using one pump versus another, because it opens the path of least resistance, which again is determined by the radius, and we know that due to Poiseuille's equation, flow through a system is radius to the fourth power. So it's a logarithmic scale that as the radius or as the diameter of tubing decreases, flow through that vessel decreases as well. So hopefully this gives you a good fundamental understanding and knowledge of what we're talking about in shunts, how dangerous it is for a practitioner to not have a good fundamental understanding of the difference between measured flow and effective flow, and which one is the most important for all of us. Again, if you have any questions, be with me either here or later after during class, and we'll see everybody tomorrow. Thanks. Bye.